Welcome to Derm School. Today, we will be looking at eczema, which is the most common skin condition that we see in the dermatology clinic. This is the outline of the talk today. Introduction, types of eczema, clinical features, as well as treatment. The word eczema comes from the Greek word eczeme, which means to boil. It is a red, scaly, itchy skin condition which is sometimes weepy. Dermatitis, on the other hand, is used more widely in America, and this means skin inflammation and typically affects the epidermis. Now, there are two major categories when you're talking about the types of eczema. So the first category is endogenous eczema, and conditions under this category include atopic eczema, which is the prototype of eczemas, aesthetotic dermatitis, also known as eczema craquelé or xerotic eczema, discoid eczema, seborrheic dermatitis or dandruff, stasis eczema, pityriasis alba, as well as hand eczema. On the other column, you see the other category is known as exogenous eczema, and these include irritant contact dermatitis, allergic contact dermatitis, and in some cases, they also include infective dermatitis under this category. In terms of clinical features, we need to distinguish between acute eczema and chronic eczema. So in acute eczema, this is a rapidly evolving red rash, which is blistered, swollen, and weepy. Over time, this becomes chronic with a long-standing irritable area, which is dark, thickened, and scratched. And patients often develop lichenification and nodular prurigo. And we shall look at these a little bit later in turn. The UK Working Party's diagnostic criteria for atopic eczema is often used. So here, a patient must have an itchy skin condition or a parental report of scratching or rubbing in a child, plus 3 or more of the following criteria. History of involvement of skin creases, such as the folds of the elbows, behind the knees, the front of the ankles, around the neck, and including the cheeks in children under the age of 10. Next, a personal history of asthma or hay fever, or a history of atopic disease in a first-degree relative in children under the age of 4. A history of generalized dry skin in the last year. Visible flexural eczema or eczema involving the cheeks or forehead and the outer limbs in children that are under the age of 4. And onset under the age of 2. And this is not used if the child is under 4 years of age. Another diagnostic criteria that's often used is referred to as Hanifin and Rashkar. And the major criteria, you need 3 or more, include 1. Pruritus, 2. Typical morphology and distribution. So this refers to flexural lichenification in adults and facial and extensor eruptions in infants and children. Next, chronic or chronically relapsing dermatitis, as well as a personal or family history of atopy. In terms of the minor criteria, in which you also need 3 or more, I like to divide them into different categories for easy memorization. So for the atopic phase, this refers to facial pallor or facial erythema, pityriasis alba, a Danny Morgan infraorbital fold, orbital darkening, recurrent conjunctivitis, cheilitis, as well as anterior neck folds. Next, triggers. These include food intolerance, a cause influenced by environmental and emotional factors, intolerance to wool and lipid solvents, as well as itch when sweating. The next category are complications. A tendency towards cutaneous infections, especially Staph aureus and herpes simplex, with impaired cell-mediated immunity. Next, immediate type 1 skin test reaction. Elevated serum IgE, the presence of keratoconus or anterior subcapsular cataract. And under miscellaneous or others, I like to put early age of onset, xerosis or dry skin, ictiosis or palmar hyperlinearity, keratosis pilaris, hand or foot dermatitis, nipple eczema, white dermographism or delayed blanch, as well as perifollicular accentuation. In terms of pathophysiology, this differs between acute and chronic eczema. In acute eczema, it is more of a Th2 response with the involvement of interleukin-4, interleukin-13, and interleukin-5. Whereas over time and scratching, you get chronic eczema, and this is more of a Th1 response with interleukin-12 as well as interferon gamma. Atopic eczema often changes in terms of the presentation at different stages of life. So in infancy, when a lot of patients first present, it is typically around the age of 3 months old or so, and it starts on the cheeks. So later, when they start crawling, it also affects the extensors of the limbs because you get friction and rubbing against surfaces as they crawl. As they get a little bit older into childhood, then you start developing that sort of flexural pattern that is so typical of atopic eczema. And this can also affect things like the feet, alright, and as they get older, it even affects the hands as well, because you start working with your hands, you start doing a lot of things, so you can encounter irritants, allergens, as well as infections. So this is a picture of a child with an infant. So this is infantile atopic dermatitis on the cheeks. Next, remember, we said as they get older, they become older children, you get flexural involvement, and there's the difference between the acute type, and with time they get chronic type, which is lichenification, alright, thickened skin, drier skin. This is a patient with atopic hand dermatitis. This is a Denny Morgan fold, which is a fold of skin under the lower eyelids due to chronic eyelid dermatitis. Lichenification refers to a change in appearance and texture of the skin, especially in itchy dermatoses. There's often subtle coarsening, leading to thickened and hyperkeratotic skin. Over time, patients develop nodular prurigo, which are chronic, intensely itchy nodules. And this is a picture of nodular prurigo. This patient has pityriasis alba, which refers to the hypopigmented patches you can see on the cheeks, and it is ill-defined, and sometimes you can also see some fine scaling on them. Eczema herpeticum is a complication that occurs when you have herpes simplex, which disseminates widely in patients with atopic eczema or other dermatoses. The patients present with clusters of itchy, painful monomorphic blisters, most often on the face and neck, and can erupt on normal or affected skin. So these blisters form and spread over the next 7 to 10 days, and the patients can be unwell with fever and lymphadenopathy. They slowly heal over the next 2 to 6 weeks, and treatment is with systemic acyclovir, whether oral or intravenous as required. This patient has staphylococcal infection of his atopic eczema. Dyshydrotic eczema or Pomphylix refers to a vesicular type of hand and foot dermatitis. Patients present with deep-seated, pruritic, clear tapioca-like vesicles, as you can see in the picture. They can form large bullae, which are known as Pomphylix. Patients also can develop scaling, fissures, and lichenification. They often have secondary bacterial infection, and this condition can have recurrent attacks. Another form of endogenous eczema is known as seborrheic dermatitis, and this refers to redness and scaling on areas with active sebaceous glands, such as the face, scalp, pre-sternal area, and body folds. And this condition is associated with proliferation of Malassezia furfur. Age of onset can range from infancy, puberty, or most often for adults aged 20 to 50 years of age. The patients have greasy, scaling macules, papules, and patches. Asteatotic or xerotic eczema is eczema due to dry skin. This is another form of endogenous eczema, and it is common among older people. Patients present with dry, cracked, superficially fissured skin with slight scaling. Common sites of involvement include the legs, arms, hands, and trunk, and there can be the presence of lichenification. Another type of endogenous eczema is known as discoid eczema. And in this condition, patients have coin-shaped plaques with grouped small papules and vesicles on an erythematous base. Staphylococcus aureus is often present. As you can see in the picture, you can see that honey golden sort of crusting. It is a pruritic and chronic condition, and it can also be known as nummular eczema. Stasis or venous eczema is eczema on one or both lower legs associated with venous insufficiency. Besides plaques on the legs, there is also hemosiderin deposition, which can be seen as orange-brown macules. Patients can also develop atrophy blanche, which are white irregular scars surrounded by red spots. And over time, they develop lipodermatosclerosis, which means champagne bottle shape of the leg with narrowing at the ankles and induration or hardening. In irritant contact dermatitis, this is a form of exogenous eczema, and it occurs in areas that are exposed to irritants such as chemicals or other physical agents, and it tends to be localized to these areas. With severe irritants, you can get toxic reactions after a short exposure, while chronic cumulative exposure to one or more irritants may also occur, and the hands are most commonly affected. Allergic contact dermatitis is the second type of exogenous eczema, and this is actually a systemic disease due to hapten-specific T-cell mediated inflammation, which is also a type of delayed type hypersensitivity. It is caused by re-exposure to a substance to which the individual has been sensitized. Patients typically present with an eczematous dermatitis in which they have itchy papules or vesicles. Common allergens include nickel, methyl isothiazolinone, fragrance, formaldehyde, methyl chloroisothiazolinone, balsam of Peru, neomycin, bacitracin, carba, and lanolin. For allergic contact dermatitis, patch testing is often used to determine which allergens are involved. Triggers for eczema can include cement dust and dust mites, soaps and detergents, rough clothing such as woolen clothes or surfaces, rubbing or scratching, frequent washing with soap, drying preparations such as calamine lotion, extremes of temperature, whether it's too hot or too cold, psychological stresses, which can suppress normal immune mechanisms, teething in infants, as well as certain foods. For example, cow's milk, fish, eggs, wheat, oranges, and peanuts, and this particularly is more for younger children. Let us now look at the 4 treatment principles of eczema, and these are moisturization, anti-inflammatory treatments, antipyretics, and antibiotics, or treating infections. There are a few different classes of moisturizers. So occlusives form a hydrophobic film to decrease your transepidermal water loss. And examples include petrolatum, beeswax, mineral oil, silicones, lanolin, as well as zinc oxide. The next major category are humectants, and humectants attract and bind water from deeper epidermis to the stratum corneum. And examples of humectants are glycerol, propylene glycol, pentanol sorbitol, urea, AHAs, as well as hyaluronic acid. Emollients smooth the skin by filling the cracks between your desquamating corneocytes. And examples of emollients are cholesterol, squalene, fatty acids, fatty alcohols, as well as pseudoceramides. And the last category of moisturizers are protein rejuvenators, and these work by rejuvenation, replenishing essential proteins. Examples include collagen, elastin, and keratin. You can also consider the use of wet wraps. So this is commonly used for pediatric patients with atopic eczema, but not when they are having an infection. So in step 1, you prepare the wet wrap or garment by soaking it in lukewarm water and wring dry. Next, after a bath, apply the emollients all over the body. And then you apply anti-inflammatory medications on the affected sites. Next, you apply the wet wrap or garment over the affected sites, and then apply a second layer of dry wrap or garment over the wet one. And finally, parents or patients have to periodically wet the inner layer to keep it moist. We now move on to the anti-inflammatory medications. So topical options include topical corticosteroids, whereas you can also have non-steroidal options such as topical calcineurin inhibitors like tacrolimus or pimecrolimus, topical PDE4 inhibitors, alright, so PDE4 is phosphodiesterase 4, and these include crisaborole or roflumilast. You can also use topical tar preparations or topical JAK inhibitors, which is currently ruxolitinib. This is quite important. It is the UK classification of topical steroids based on the potency. So for mild topical steroids, you can use them for areas of thinner skin or even mucous membranes for short periods of time. Whereas for thick lesions or thicker skin like on your hands and feet, you will need a potent or even a very potent topical steroid. So let's go through these in turn. So class 1 is very potent. And typically, this refers to your clobetasol propionate 0.05% cream or ointment. Class 2 are potent topical steroids, and these include betamethasone dipropionate, betamethasone valerate 0.1%, diflucortolone valerate 0.1%, fluocinolone acetonide 0.025% cream, fluticasone propionate 0.05% cream, mometasone furoate 0.1%, either cream or ointment, and triamcinolone acetonide 0.1% cream. Class 3 are moderate topical steroids, and these include betamethasone valerate 1 in 2 dilution or 1 in 4 dilution, either cream or ointment, as well as clobetasol butyrate 0.05% cream or ointment. And the last class are class 4, which are very mild topical steroids, and these are betamethasone valerate 1 in 8 or 1 in 10 dilution, either cream or ointment, or typically we also use hydrocortisone acetate 1% cream or ointment. What is a fingertip unit? So this refers to how much cream or ointment should be used. So this is an important concept to explain to patients when you are counseling them about the use of topical steroids. So use your index finger to measure, and 1 fingertip unit is the amount of cream or ointment squeezed along the index finger from the tip to the first joint, as you can see in the picture. And in an adult, typically 1 fingertip unit is about 0.5 gram to cover the size of 2 palms of the adult. Okay, and you can see below there's a diagram which is a general guide of how many fingertip units per body area that you want to apply to. For children, this depends on the age of the child, and the fingertip unit needed, as you can see, is illustrated in the table below. Systemic treatment options for anti-inflammatory medications include corticosteroids, cyclosporine, azathioprine, methotrexate, and mycophenolate mofetil. And in recent years, we have been very privileged to see the advent of newer therapeutic options, including biologics for atopic dermatitis. Examples include dupilumab, tralokinumab, and lebrikizumab. The most commonly used in our scenario is currently dupilumab. We also have JAK inhibitors such as upadacitinib, abrocitinib, and baricitinib. But watch this space because more and more newer drugs are coming on the scene. We can also use phototherapy, which is basically using ultraviolet light in a cabin, or you can see the machine there, that the patient will go into for the treatment. So antipyretics, what is the role of antipyretics? So you can prescribe sedating systemic antihistamines to improve the sleep. However, the quality of the sleep will be compromised as compared to the usual patient. However, topical antihistamines are not recommended as there's the risk of sensitization leading to allergies. Next, you have to treat any infections appropriately. So even though I term this as antibiotics, you can actually refer to a range of treatment options for infections. So for bacterial infections, we can prescribe topical or systemic antibiotics, antiseptics, such as the use of antiseptic washes or bleach baths. For eczema herpeticum, which is a viral infection with herpes simplex that we spoke about earlier, you need acyclovir. For fungal infections, we need to give them topical or systemic antifungal therapies. So once again, these are the 4 treatments for eczema: moisturization, anti-inflammatory, antipyretics, as well as antibiotics, or treating infections appropriately. This is the stepwise approach, okay, which is recommended by the NICE guidelines. And you can see in mild atopic eczema, you rely more on emollients as well as the use of mild potency topical steroids. In moderate disease, once again, emollients is the mainstay, but you also start looking at moderate potency topical steroids, topical calcineurin inhibitors or immunomodulators, as well as bandages or wet wraps. In severe disease, besides using emollients and adding on potent topical steroids, you also think about topical calcineurin inhibitors, bandages, and then you have the role of phototherapy or systemic therapy. Other treatment options for specific types of eczema. So for instance, if you have seborrheic dermatitis, you also want to think about adding on things like 3 to 5% salicylic acid to reduce scaling, imidazole, antifungals or shampoos, tar shampoos. Simpler options which you can buy are selenium disulfide shampoo or zinc pyrition shampoo, as well as the use of low potency topical steroids. For patients with venous or stasis eczema, besides the 4 main treatments of eczema, you will also want to treat varicose veins. So the take-home message, you have to know the different types of eczema, alright, the different presentations, whether it's acute, subacute, or chronic eczema. Know the various types of endogenous and exogenous eczema, as well as the 4 principles of treatment. And with that, I thank you.